dear URTICARIA lovers. Here we are in a new UCARE LevelUp webinar. Maybe you are asking, what is UCARE LevelUp? UCARE LevelUp is a program of the URTICARIA References for and Excellence Centers, which is dedicated to the education of physicians on the management of urticaria and increased care for urticaria disease. I am Emek Kocatürk Göncü. I'm a dermatologist who has been treating dermatology patients for 20 years, and I can say that skin and mind are closely connected. And a lot of diseases are associated, are linked to the psychological state of the patients, and one of these diseases is urticaria. So here today, we will be speaking about the mind and body interactions in urticaria. And we have distinguished colleagues who will be speaking about this topic and who are experienced in this topic and have publications on this topic. So the first speaker is Anna Zalewska-Janowska from Poland. She will be speaking about the prevalence of psychological comorbidities and how to recognize them in chronic urticaria patients. And our second speaker is Ivan Cherez from Ecuador, and he will be speaking about alexithymia and sleep disorders in chronic spontaneous urticaria. And Indrashish Podar from India will be speaking about the effects of psychological treatments and interventions focused on well-being on urticaria. So we have very interesting topics, and we will all learn together. So the agenda will be like this, and we will have the questions and answers at the end of the session. So please write your questions in the question box or in the chat. We will be very happy to answer all your questions, and we will be happy to discuss with you the psychological aspects of chronic spontaneous urticaria. So this is you see, we have a lot of registrations. We have 136 registrations from all over the world, from 37 countries. And thanks for being here. I want to say hi to all of you who are joining from all over the world. So it will be a very pleasant webinar. And you can earn CME points by filling out the feedback form at the end of the webinar. So please fill in the form at the end of the webinar. So now, and please, the questions we will answer at the end of the webinar. So now it's my great pleasure to invite Anna Zalewska to speak about the approach to patients, chronic urticaria patients with psychological disorders. So welcome, Anna. We are very happy to have you on board, and we are very excited to hear your talk. Please.
Many thanks, Emek. Hello, everybody. And it's my great honor to share with you some of my, shall I say, experience, personal experience from my consultation room. May I have the next slide,
Anna, please, excuse me for interrupting, but please, can you speak about your position in the Psychodermatological Society? Excuse me.
So actually, I am... first of all, I have three specializations. So I am dermatologist, allergist, and clinical immunologist. And I am head of the psychodermatology department and the chair of pulmonology, rheumatology, and clinical immunology as regards Medical University of Łódź in Poland. And I must tell you that because, you know, psycho, it's a little bit stigmatizing, I should say, still. So being in such huge chair, you know, somatic chair for psychodermatology is very good, destigmatizing, and extremely useful. And I must tell you that actually being clinical immunologist I have 95% of adult patients who have psychoneural problems. So actually this holistic care, so it means taking care and actually tackling and touching the stress issues is crucial.
Yes.
And of course, I'm a professor, shall I say? Modestly, I'm a professor. At the end of the day, it's high time. Okay, many thanks. So may I have the next slide, please? No conflict of interest as regards this presentation, and shall we go to the plan of presentation? I would like to actually present briefly two literature data on psychological comorbidities in chronic urticaria patients, most commonly encountered. And then I will go to my little tips, how I approach chronic urticaria patients in my, shall I say, 3-in-1 specialization, because as I said, I am a dermatologist, actually also venerologist, allergist, and clinical immunologist. And everything actually as regards this communication is based on stressors. So taking us out of the balance once there is such a problem. And then I will go more deeper, maybe in a stress definitions type, how to deal with stress, which is everywhere. And then I will share with you my subjective selection of prompts that we use actually when we have a lot of time with the patients and for more research, or when we do interdisciplinary and multi-center studies with EMEC and the rest of the team, Ivan and Indrashish, because we are very supportive. And then I will finish with ABC, such a rescue kit, toolkit, what to do actually when the patient comes for miracle. So one of the literature data which I would like to share with you was already published in 2006. And Dr. Staubach and her co-workers, really what they found, that actually 1 in 2 patients have problems with anxiety, depression, or somatoform disorder. So actually every other patient has something as regards, this neuropsycho stuff. And then we have 2019, or then the team Constantino actually perform a systematic meta-analysis of chronic urticaria patients. And they actually selected 25 studies, not much really, because it's not easy to study, but 25 which were eligible to PRISMA. And they found that every 3rd patient has problems, mostly anxiety, depression, but still, you know what I mean? I am not a psychiatrist. I am not a psychologist. And I'm trying, you know what I mean, not to go too deeply on the first stage with this issue in order not to get drowned, because it's very, very, very challenging and time consuming. And we have, fortunately, at the psychodermatology department, we have an interdisciplinary team. So the 2nd consultant is psychiatrist from the team, and the 3rd psychologist, not the other way around, in order not to miss something somatic. May I have the next slide, please? A slide? Yeah, perfect. So how I approach the patient. Very often the patient comes to me and already have big files of documents and nothing is working. So I'm starting from scratch, from the very beginning. And I am asking about, I'm actually saying about the environmental stressors. So changes in the temperature, weather, food, allergens, some irritation factors. Actually, I'm leaving psycho stress at the very end in order to actually approach the patient from the somatic part and not to create more stress on the patient. And then I am saying few words on the connections of skin and nervous system, because they are anatomical connections. Their skin and nervous systems are siblings. They are very, very similar. And actually, there is a skin and brain axis also in the skin. There's this counterpart, and there are a lot of transmitters. And mast cells, which are crucial cells in our beloved urticaria, are very close to the blood vessels, are very close to the neurons. And actually, there are a lot of neuroreceptors on the mast cells, and mast cells release all the mediators when they are agitated as regards stress and stimuli going through nerves. So neurogenic inflammation develops, neurogenic, still inflammation, still it's crucial, it's somatic, it's biologic, destigmatizing. And then I am also talking about itching in order to show the patient that, itching impulses go via nerves. So I'm telling the patient that, your nerves are more susceptible, and itching is even worse than pain. So it's extremely difficult to overcome that. And the patients see I understand them. I am next to them, actually. I take care. And then, I'm talking about the immunological system, endocrine system, stress axis, pituitary, hypothalamus, pituitary, adrenal axis, sympathetic, adrenal, medullary axis, as regards, all these stresses. And crucial stuff, I'm saying that they are actually more susceptible. They're exceptional. They were born to be princesses, prince, and they need more care. And the people always smile, and they are very, very, very pleased with that. Even today, one of my patients say, "Oh, prof, that I am in this group of patients very susceptible in the society. You know that there is 20% of such patients." And I said, "Yes, I know. And I do appreciate, and we will fight together." May I have the next slide, please? So a few things about stress. Stress as something which is on an everyday basis next to us, within us, around us. It's normal, it's physiology. Stress is also progress. It's evolution, it's challenge, it's life. And you stress, it's a good stress, which is motivating. But of course, this stress, it's a chronic stress, demotivating, and actually very, very, very challenging and disturbing. So if somebody tells me that he's not getting stress at all, I already know that there will be problems as regards taking care of the patient and taking under control her urticaria, because it's normal. So destigmatizing that. And I'm always saying, it does not mean that you are crazy. It's nervous system that is most powerful. And I would like to warn you about one thing. Once you get into psychoneuro stuff, it could be that your colleagues would think that it's a perfect idea to send you the most difficult patient, that they cannot spend that much time because you are a miracle person. It's not that. I'm always saying, sorry, I have no power, but we will work together, and I have the team. Because remember, don't take everything on board, in case you are a psychiatrist, psychologist as well. But I am not, and I won't be in this life. So I am asking for help, and I am actually sharing my responsibility and my knowledge and my experience with the rest of the team. May I have the next slide, please? So subjective selection of prompts, because I wanted to show, once you want to go in this direction and can gather questionnaires and spend that much time, people like that. However, overdoing, remember that overdoing, it's even worse than underdoing. So, because our patients are with us for some years, it's good to, shall I say, not to overdo. But as regards stress, it's 10, it's very nice scale, perceived stress scale, 10 items. and stress situation are covered there. And there are two scales that you can use. One, DAS. I like this one, DAS 21, Depression, Anxiety, and Stress Scale, or a Hospital Anxiety and Depression Scale to check depression and anxiety. Of course, as for, I'm not performing on an everyday basis CUCWAL, which we validated with Professor Brzoza and his team. However, because it's 23 items and it takes some time. And of course, we do that, but not on an everyday basis. But I love two questionnaires on coping, because you know what I mean. We are under stress. We have a lot of stress. We are taken out of the balance. But if we cope, if we function, everything is okay. Because you know what I mean. Fluctuation, it's normal. However, going to the balance next, it's crucial. What we are doing on an everyday basis, maybe not on an everyday basis, because DLQI, it's asking for quality of life for the last week. But it's only 10 items, freely available, and 2 minutes. People just spend only 2 minutes. It's adult version. However, there are also children version. And what is extremely important that we have in here ranges of how quality of life is impaired. And on that, we can build and ask further as regards different symptoms. And there's also minimally clinical important difference, which is 4 points. So actually, when the patient comes to us and fills it in, we see the difference, whether it's clinically important, which is crucial as regards, stepping up, stepping down, as regards treatment. May I ask the next slide? Yes. Yeah. And once again, my ABC Psychoneuroimmunokit. Education. Sorry for saying that, but it's time. But education, people really love to know what's going on. Skin nervous system from the same part of the embryo, close, very close siblings, and it's normal, absolutely normal, that central nervous system is stimulating mast cells, so our urticaria cells, and our urticaria can get worse. So we should learn how to cope, being taken care of, and, sensitive, special, individual. That's crucial. We are partners as regards the patients. We love to help patients, but remember that patients are with themselves 24 hours a day, and they have to cope by themselves. We are not with them. So delivering this message, but taking care of, it's crucial. May I have the next slide? So building trustful relation, very important. And, not too much pushing in the psycho nature. If people say, no, stress is okay, I know that it will be difficult to handle patients, but still give time to the patient. Give time. I'm asking many times, if you function, it's okay. We'll deal with pharmacology. Don't worry. It's normal. You decide. It's not life-threatening. We are together. And extremely important stuff. If you want to send a patient to a psychiatrist or psychologist, please do have first a team. And actually don't send patients to a psychologist or psychiatrist somewhere, because the psychodemo, etc., it's, shall I say, more luxury stuff. It's that people are not standing at the edge. They need more time. And if you send somewhere just out of the blue, the patient can come and say, oh, doc, prof, nothing is wrong with me. Maybe something is wrong with you. So remember, it's crucial. Having a team. And to have fun with all that, it's to have a team, and it very much helps in prevention of burnout syndrome. Remember, in order to help others, we have to be balanced ourselves. First things first, as oxygen mask on the plane, first on ourselves, then on our children, who are much more important to us. But if we faint, the child is gone. Okay? May I ask for the next slide, please? So take-home messages: education and care of the patient. In the first place, destigmatizing psychoneuro issues and interdisciplinary team cooperation. And DLQI used every 7 days if possible. Anyway, when the patient comes, because it's last 7 days. But not too overdoing, because patients are very, shall I say, agitated as well. So focusing on numerous questionnaires, it's almost impossible when they come for the consultation. And may I have the last slide, please? May I invite you actually to check our special issue on frontiers and neuroimmunoendocrinology topic, and all actually on the topic on this neuropsycho immunological issues, all the kinds of articles are welcome. So it's very I will be most happy to actually assist you with this whole process. Many thanks for your kindest attention.
Thank you, Anna. This was a wonderful presentation, very insightful. Really, I think your patients are very lucky and they are feeling like prince and princesses after your consultation, I'm sure. And the message is important. We are in this together, really feeling we are together with the patients. It's really important. So I think our friends will be also interested in submitting papers to your special issue, especially urticaria and psychological conditions. It's a very hot topic. So now it's my pleasure to invite Ivan Cheres from Ecuador. Ivan is very famous with his UCARE projects. Ivan, is any of your UCARE projects about this topic? And welcome. And we are really happy to be hearing from you.
Thank you, Max. Thank you all for this inviting to me to this meeting. I really enjoy the Anna lecture. I guess we teach a lot of things. I don't know what the problem with my... Okay. I don't have any kind of conflict of interest for this lecture. First, I would like to thank the organizer for inviting me to present this topic, but it's so relevant as it's very important in the current days. If several skin diseases are known to significantly affect patients' quality of life and health, all of the mental health disorder. Recently, a study evaluated the burden of the most common pathological diseases in adults across Europe. They found that more than 80% of the participants consider their disease to be embarrassing in their personal life and their work life. And you can see all of them report anxious and depression. It's important to highlight the psychosocial issues experienced by people with skin disease and the need to address the impact of their quality of life and stigmatization in the context of the patient management. Anna told us the importance of the psychological comorbidity, and she referred this paper. I would like to address this meta-analysis where the principal psychiatric comorbidity was sleep weight disorder, included insomnia and restless legs syndrome, where the pool prevalence was 36.7%, followed by anxiety disorder and mood disorder. However, there is another important disorder with a high prevalence in cutaneous disease, and is what not evaluated in this meta-analysis. Actually, we evaluate this disorder in psoriasis, and we find a high prevalence. I am referring to alexithymia. Alexithymia, by definition, is the difficult for a person to identify his or her symptoms and to describe them. The patient or the people have difficult to express their feeling and difficult to communicate this feeling with the physician. To diagnose alexithymia, the 20-question self-report Toronto alexithymia scale is used. When the score is equal or greater than 61, alexithymia is confirmed. And sometimes we have possible alexithymia when the score is between 52 and 60. In chronic urticaria, it has been suggested that alexithymia is not influenced by severity of control of the disease. Moreover, it is influenced by gender because alexithymia affects female more than males. But there is an inverse correlation with alexithymia and quality of life and another topic. But we guys think about what is really known about this topic in chronic urticaria. As mentioned in the meta-analysis, 30% of the individuals with chronic urticaria have a poor prevalence of anxiety and mood disorder. Moreover, there is a few studies with a small sample size that have shown a 50% of alexithymia in chronic urticaria patients. For this reason, we decided to develop a study in order to fill this gap. These were our three objectives in our study. First, to explore the prevalence of alexithymia. Second, to assess the association of alexithymia with the degree of control and severity. And finally, if there is an association with therapeutic profile. We designed a cross-sectional multicenter study in 3 continents, which included a total more than 400 participants. All of that had chronic urticaria. The task 20 was applied, and the results indicate that 42.1% had alexithymia. Of these, 61 were female. 21.5% had possible alexithymia. In addition, that is important, the results, we found that CU activity was lowest in patients without urticaria. In contrast, those with alexithymia had a higher proportion of moderate or severe chronic urticaria. Last but not least, participants without alexithymia were found to have a highest proportion of controlled urticaria. However, when we apply ordinal logistic regression prediction of just 20 categories of alexithymia, look at that. We found that patients with non-controlled urticaria had 68% higher odds of having alexithymia. Surprisingly, the finding in our results, in our study, revealed that patients who had a mild activity by using UA7 still had a double probability of suffer alexithymia. And this should be an alert to consider when we have patients with chronic urticaria to use these 2 prompts, UCT and UA7. Because remember, although the chronic urticaria is mild, alexithymia may still be present. It was unexpected to find that the use of older first-generation antihistamine double the risk of alexithymia. As you can see in this chart, when you use second-generation antihistamine, you don't have problem with the alexithymia. In addition, we found that the prevalence of alexithymia when the patient in mental disease comorbidity was 16.3%. As you can see, the patients who have comorbidity mental disease has double the chance to have alexithymia. Furthermore, these patients with this mental health comorbidity are more likely to receive first-generation antihistamine, showing that there is a positive association between mental illness and the use of all antihistamine. Research shall be conducted in the future to determine whether first-generation antihistamine may be contributing to the worsening in mental health condition. Another relevant finding is that patients with cardiovascular comorbidity were 2.5 times more likely to have alexithymia. The clinical message is that we should be alert with dealing with patients with cardiovascular comorbidity who have non-controlled chronic urticaria despite receiving correct treatment. Because jumping to my second topic, it is well known that the sleep disturbance has been associated with adverse health outcomes, such as increased risk of heart disease and strokes, increased stress, increased mood disturbance. As a result, it is believed that CU patients are more likely to experience health problems if they do not sleep well. According to a recent publication that I mentioned a few minutes ago, the majority of the patients reported sleep disturbance in urticaria, followed by tiredness. And if you look at this graphic, the influence of the sleep is in different skin diseases. But there is a wide range of this condition of this sleep disturbance. Regarding this, the third edition of the International Classification of Sleep Disorder considers 7 major categories, which are insomnia, sleep disorder breathing, parasomnia, among others. Recent studies suggest that CU patients have an increased risk of sleep disorder breathing. As proof, a previous article found that 52% of the patients or CU patients had sleep apnea, confirmed by polysomnography. And there is important to the correlation because there is a positive correlation between US score and apnea-hypopnea index. If you have apnea-hypopnea index, you have more activity of the disease. Unfortunately, polysomnography is not available everywhere. For this reason, we decided instead to develop a research using a simple questionnaire, a stop band questionnaire, which has the capacity to classify individuals with high, intermediate, and low risk for sleep apnea. We included in our study 161 patients. Most of them were severe, uncontrolled, and were affected quality of life, especially in the sleep domain. The stop band questionnaire revealed that approximately 4 out of 10 CU patients had a high to intermediate risk for sleep obstructive apnea. Our results suggest that the higher disease activity, poor CU control, and worse quality of life were all associated with a statistically significant increased risk for sleep apnea. So, it is valid to perform routine screening using to stop band and to treat CU patients for sleep apnea to improve clinical outcomes. This is a question that we expect to answer in the near future because, as you can see in this study, this study found more prevalence of sleep disorder breathing and is associated with more severe chronic urticaria disease. But I guess the most important result is when the patient received treatment for the sleep apnea using CPAP, decrease the activity of the chronic urticaria. What is the limitation of this study? That they only treat 4 patients. But I guess in the future, probably we have more information, and this is the way that in the future we need to demonstrate with better studies. However, there are more sleep disorders that haven't been explored in chronic urticaria. We believe that a study should be performed to find this prevalence, and we present this project to the steering committee UCARE, and thank you for all of the UCARE Center to be participating in our study because we have a lot of survey. We use this questionnaire, Global Sleep Assessment Questionnaire, because this questionnaire that can aid in recognize sleep disorders such as insomnia, restless leg syndrome, parasomnias, sleep obstructive apnea. Consequently, I am excited to present you our preliminary results. We found that summing all the cases of chronic urticaria, controlled and not controlled, the sleep apnea is the who has the highest prevalence in the patient with chronic urticaria. However, looking for only uncontrolled urticaria patient, insomnia has the highest prevalence. As you can see, when we ask for anxiety depression, we have a high prevalence of this disorder. Our finding highlight the importance of searching for a sleep disorder in all CU patients. For this reason, we propose this algorithm when you are managing a chronic urticaria patient. Besides paying attention to activity, to control, and quality of life, we recommend looking for mental health and sleep disorder using the different validated prompts. Finally, I would like to give you a take-home message. Patients with chronic urticaria had a high prevalence of alexithymia and a sleep disorder, which is associated with more severe and less well-controlled disease. We must be alert and think about this disease in order to avoid a timely diagnosis and avoid complications. We need to obtain a timely diagnosis and avoid complications. And finally, we suggest to always have a multidisciplinary team to offer a comprehensive and accurate management of the disease and improve the outcome in chronic urticaria. I was thinking when Anna told us, and I probably guess that the colleagues send the patient thinking that Anna is similar to a witch, but for the patient is a good mother because she understands their problem. In conclusion, suppose that you forgotten my lecture. You don't have time for use prompt because Anna teaches us that we need time with our patient and we need to use different prompts. It is my intention to communicate a simple and clear message to you. I advise you to always ask the following question in your medical history in chronic urticaria patient. First, do you snore? If the patient answers yes, then you should use the stop button aiming to sleep obstructive apnea. Second, if the patient, do you ask this question, do you fall asleep when reading or when watching TV? If the patient answer affirmative to one or both, then you should aim at the sleep disorder using GSAC. In the case that the patient answers no to both questions, then the negative predictor value is 99%, and therefore it is not necessary to investigate for sleep disorder. Thank you very much for your attention, colleague.
Thank you so much for giving this important tips for the practitioners. So for the practicing physicians, I see that there are many thanks from the chat box that I think our colleagues will be using these tips in their practice. So thanks a lot. There is a question. So everybody's thanking to Anna and Ivan. So Paulina is asking, have you seen differences in the frequency of sleep disorders in different age groups? Ivan, this is a question for you.
Yes. Okay. We are analyzing the data, but it's a preliminary result. Patients who are all age, they don't have much problem in anxiety and depression. It's more frequently in young people. It's a preliminary result, but I hope to complete all information for the next 4 level UCARE, you need to invite me again.
Maybe we will hear in the Sao Paulo, Brazil UCARE meeting. I'm looking forward to it, Ivan. And it's my pleasure to welcome Indrashish Poddar from India to speak about these psychological interventions. So we will have, I think, some insights if they are working or not. Please, Indrashish.
Okay, thank you very much, Umesh, and the whole team for inviting me. And after this wonderful lecture, I'll just walk through about some of the interventions, psychological interventions on urticaria. Okay, so this is my conflict of interest slide. So there are some unmet needs. So we know about urticaria. We know that it's quite a prevalent disease, and the current treatment regimes are all known to us. The problems start when we come to assess that almost 60% patients, that's a lot, that's almost 2 in every 3 patients do not respond to even to updose second generation antihistamines. Of course, the response rate of omalizumab and cyclosporine are better, but they're expensive, their availability is limited. So in most part of the world, second generation antihistamines are something which are considered the most important treatment, and almost 60% patients do not respond. And this constitutes a very important unmet need and challenge for all of these chronic spontaneous urticaria patients. Can I have the next slide? So this is something we're all aware of. It's just for recapitulation, the guidelines. Okay, next slide. This is also something we know how to assess the treatment response. The UCT of 12 is the mark. Next slide. So now, what is the need for this psychological interventions? This is already been discussed very nicely, that we have a lot of these patients actually suffer from these psychological problems. And Ivan also discussed about something which is coming up, alexithymia. So that's why psychological interventions may be tried in such patients as add-on, because we have already discussed that almost 60% patients do not respond to second generation antihistamines also, even after updosing. So it's always good to try this psychological interventions in these patients as an add-on therapy. And not only are these psychological interventions helpful to improve the quality of life, sometimes they also improve the response to currently existing therapies. That I think also is a very important point, that they can actually benefit the patients from the therapeutic point of view also. Now, this is very important, that we always think that mind and body are something separate, that if a person has got some kind of a somatoform disorder, we label it as kind of a psychological disorder, and we don't pay heed to the bodily problems. But this concept needs to be modified, and we need to have a more of a unified concept where it's now believed that both mind and body work in together and they work in sync. So a person who is sick physically will also have some problems or some disturbance mentally, and this has already been shown by the recent publications by multiple authors across the world. And so for these reasons, we need this add-on psychological counseling support and patient education, not only to improve their quality of life or to improve their disease status, but also to improve the therapeutic, to provide them the therapeutic benefit to existing therapies. Can I have the next slide? So these are some of the publications. I'll not go through. We have already gone through a lot. There are systematic reviews also. The important ones are the later publications, where we are now finding that what is the link between this psychological or psychiatric conditions and maybe say chronic urticaria, that there is the increased substance P levels. There are increased of nerve growth factors, which are actually stimulating the mast cells. As Anna also told us, the nerve and skin are actually from the same embryonic origin. Next slide, please. Now, mind-body factors have been reported as early as 1940. So now, this is what I was talking about, that we have gone through this lecture seeing that how these psychological conditions can, affect the quality of life, and they can affect the severity of the disease. But I will now show you some publications which show that this is also important from the therapeutic point of view. Like this publication where EMEC was also a part of this, you can see that the number of omalizumab non-responders were significantly high if the patients had depressive symptoms. So if you are treating a patient with urticaria who is having concomitant such psychological conditions like depression, these patients may be non-responders to the existing therapies. And that is a very important point. It's not just enough to step up your therapy, as the guideline says. Sometimes you need to do these psychological interventions, and they may be helpful also. Next slide, please. This is again another study from Turkey, from Andaf and his team. And this also shows us the same thing, that you can see the US7, UCT, DLQI, and QPOL scores. They may be a better predictor of response. So, or in other words, we can say that if these scores are raised, if the patients have got a very depressed quality of life, they will also be poor responders to omalizumab. Next slide, please. Now, is it only omalizumab or second generation antihistamines are also affected the therapeutic response? This is a very beautiful paper from Jason Folk and his team. And you can see that if these patients have a high DLQI, which Anna was referring to, that is a very poor quality of life, they can also be poor responders to even second generation antihistamines. Next slide, please. Now, among all the psychological morbidities, stress is something which has been researched upon a lot, especially in urticaria, and we are all aware of it. That stress is one of the important modulators of urticaria, and it actually, we have all know that how it actually affects the mast cells, and then it leads to the release of the mast cells, and it leads to urticaria. This particular diagram has been taken from Anna's paper only, where we have already described that there is the exacerbating factors. It's not only something which worsens the disease. They can also exacerbate the disease. They can worsen the therapeutic response, and they can also shorten the remission time. So it's not only the pathology of the disease is affected; it also affects the therapeutic viewpoint of the disease. Next slide, please. Now, the instruments have already been discussed. I personally prefer the HADS, which is a simple scale, and of course, quality of life, which should be assessed in every patient. Next slide, please. Now, I'll go through some of the pharmacologic measures which are available currently for treating this kind of morbidities in such patients. There's a very beautiful review article, and you can see a lot of antidepressants have been used because they have also anti-inflammatory effects. And we know that urticaria is an inflammatory disease. Among them, the most prominent is doxepin, but others have also been used like nitazepan, fluoxetine, amitriptyline. What I want to suggest from this stage is that we can give a trial of these medications if the patients are not responding to the currently available ones, instead of just stepping up the treatment or going for more expensive ones like the biologics, which are not widely available. So we can always give a trial of these medications in such patients, and especially if we find that they have psychological morbidities by the scales which our previous speakers have discussed. Next slide, please. This is just the mechanism. I have just put this diagram to show that how these antidepressants can act. They reduce the stress, they can act on the HPA axis, and they also act on the serotonin levels in our body, and that's how they reduce depression. And not only depression, they also reduce the inflammatory markers like interleukin-1 and TNF-alpha. It's just one of the ways by which they also modulate the disease process and improve the disease condition. The next slide, please. So what are the different psychological interventions which have been tried? We have already talked about this unified concept of mind-body concept, which is very important. The most important ones are the various anti-stress techniques or relaxation techniques. You can see some of them which are mentioned: visualization. This is the most prominent one, this Jacobson's training or progressive muscle relaxation technique. And mindfulness training is also very important. You can just practice meditation and yoga. These are very important and very effective mindfulness techniques. But it's always better to, once you find such morbidity, it's always better to refer your patient to a trained psychologist. Of course, in your team, as Anna mentioned, the importance of forming a team rather than doing these things yourself, because we are not the experts in this field. So next slide, please. Now, I'll walk you through some of the evidences in literature about this mind-body intervention. This is a publication, very, very old publication from 1973. You can see behavior therapy improved urticaria and severe headache. Next slide, please. Again, we have already seen the benefit of relaxation therapy. We have it's basically an anti-stress technique. So relaxation techniques and hypnosability in chronic urticaria, they have also been found to be effective. Again, an old paper, which is before 1990s. Next slide, please. These are again some of the other techniques which can be used. These are more of a psychologist domain, but I'm showing these slides to impress upon the fact that these are some of the techniques which can be tried in such patients, especially to those who have a very severe disease. That means they have also a very impaired quality of life, and to those patients who are not responding adequately to the current therapies. Next slide, please. This is a relatively recent paper. It also, shows us another psychological treatment approach, and this is a proof of concept study. This has not been studied in very large trials. Next slide, please. This is again another study, an 8-week attention-based training program. One thing is very important, which Anna also mentioned. All these techniques are very time-consuming techniques. They need patience. They need proper professional support. So these are very time-consuming professional techniques. So they should be, if you find such patients, they should be referred to your psychologist colleague in your team for the optimum care. The next slide, please. Now, these are some of the other studies which have been done, which regarding mindfulness. We all know this is a very emerging concept, not only in urticaria, even in a lot of studies in diabetes, in hypertension. So this is one emerging area of research. So that's also translated to urticaria and other allergic disorders like atopic dermatitis. So you can see a lot of publications are recently coming up where physicians are exploring whether these techniques are beneficial, and they have been found to be beneficial in various inflammatory disorders and the allergic disorders, including urticaria. Next slide, please. Now, other interventions, sleep hygiene is something that's very important. I want to stress, because this is a very simple thing which needs to be done, because we have seen that urticaria patients are also sleep deprived, most of them, almost 2 in every 3 patients. So if you can just maintain such hygienic techniques where, not seeing the mobile phone for a long time, maintaining a dark and ambient environment for your sleep, and these things can improve your sleep, so they can be beneficial for such patients also. Next slide, please. These are some of the other techniques, not in urticaria. So what I want to stress is not only in urticaria, but other pruritic conditions also. These techniques have been tried, relaxation techniques, various techniques, cognitive behavioral therapy, which is probably the most well-known among these techniques. And they have been tried in some other pruritic conditions like atopic dermatitis, psoriasis, prurigo. So they have found to be quite beneficial. But the most important point is that patients' understanding about the disease. So what it translates is that proper counseling of the patients. We need to explain to the patients properly about what their disease is and how we can, improve them. Hand-holding is of very importance in such patients, as Anna said, that proper counseling is the key to address these issues. Next slide, please. So these are some of the take-home messages, or you can see the way forward, that how we can implement these things. That, as I've said, psychological factors are important in CSU. They not only worsen the disease, they not only make the disease more severe, but they can also affect the treatment, which is very important. These factors may be responsible for non-response or inadequate response to the existing therapies. We unitary model rather than a dualistic mind. It's not mind or body, rather it's mind body together, because if one is affected, the other is also affected. It's not or. And very important is that we need systematic clinical trials with these psychological therapies. It's not the major lacking is that all these have been tried in a very few patients, hardly 15 patients, 10 patients, something like that. But I think we need to have more focused and more well-designed trials where we are maybe giving this psychological interventions to one arm and along with the accepted therapies to find whether actually they are beneficial. One must focus on the individual patient stories. Of course, each patient has a unique story, has a unique experience. So we need to hear to them rather than just labeling them as depression, anxiety, stress. So this is important. And that's all from my end. Thank you very much.
Thank you very much, Indrashish, for your insightful presentation. It's really important. Yes, this message, unified approach, mind and body are together, and we shouldn't separate them. And really very interesting interventions. And maybe you are making a UCARE project on the psychological aspects of urticaria. You already started.
Yeah.
I have the idea. Indrashi, I have an idea for you.
Yes, yes, of
Okay.
course, of course.
One
Yeah,
has super
want to-
ideas all the
I
time.
want to say, it's possible to say a question for Indrashi or for Anna. Yes.
Yeah, please go ahead, Ivan.
Are you
Yes,
using,
yes, please.
what are you using for applying your patient mindfulness training? Do you use this, or you send to the psychologist?
No, I usually do a counseling on the when they are to me. So sometimes if they improve with just the counseling, I don't apply these techniques myself. Maybe only meditation, yoga, and sometimes this kind of relaxation techniques are very helpful. But otherwise, I usually refer to some of my psychological colleagues actually, for the professional part.
Okay, so I'm checking if there are any other questions to you. So many thanks from our colleagues, Rosalie, Rabia, and Paulina, Erica, many of our friends, Morfin, Blanca Maria. Yes, thanks for being with us, Alejandro, Carlo. Okay, thank you. And Marcus is also thanking. So Lawrence, Ines, thanks, Daudi, and many others. Thank you. But any other questions? Ivan, do you have another question?
Yes, I have problem with my electricity in my country, and we broke at the moment. But think about Indrashi, because I guess that could be interesting if you prepare a proposal for UCARE using mindfulness virtual reality, because for me this is the future. Okay, think about you put that. I think that it's a good idea, because Anna told us that you don't have chance to put inside in our patient. We say, okay, go to the psychologist. But sometimes the patient say, doctor, I love you. Anna, I love you. You are my psychologist. Yes or no? That is the real time.
Yes. These are very important aspects.
Yes, and if we prepare a mindfulness virtual reality using the information and communication technology, we have chance to increase the outcomes, the better outcomes in our patient. Think about we talk later about this.
Yes. And
you invited
sure. We will.
Yes, Anna, and I like your mentioning that if you speak about stress at the beginning of the counseling, then you are like stigmatizing the patient, and I liked your approach on that. So you are coming to the stress point later during the consultation, I guess. Would you like to talk about it?
Because stress at the very end, and environmental stress is taking out of the balance. For example, eating something is also stress. Okay, for the for our digestive system, and because you know what I mean. Once somebody is really agitated and on the edge, when you say, "Oh, you are nervous," you say, "No way, I'm
more
not
nervous than
I am very quiet." So, oh my god.
Yes.
Me being an extrovert, you know what I mean.
Yes.
So it's normal.
And another question, please, can I ask? So, do you think, as dermatologists, we can start antidepressants to our patients? So, what's the point, or where shall we start doing it?
We can always
depending
start
on the back depression scores, or just
we can always start. However, because I having 20% of my physician job at the psychiatry department, I'm always, because I'm lazy, I'm always asking my psychiatric colleagues why. Because you know what I mean? We are doing this screening tools, but still it could be only a mask of something. And to me, if I were in a remote place and I will be stuck, I would introduce, for example, as regards SSRIs, I would introduce escitalopram, 10 milligrams, no problem. However, because if you want to help somebody and there is something else, you know what I mean? You actually are giving chance to your colleagues who work in the court. So, you know, I would like to stay on the safe side and not giving. Of course, you know, there are always general practitioners to ask.
Yes.
Why not? So sorry, because I'm lazy. But of course, everybody can prescribe. However, you know what I mean? A depression mask, it's not everything. It could be something else. And then it's better not to start. However, as regards continuing the treatment and having more visits with me than with psychiatrists, we do that. However, it's still, I want to be on the safe side, and I love to help people, you know, but I love to help myself even more. Sorry for that. But I'm actually also delivering this message to the patients. And nobody never ever said that she expects something else.
Okay, thank you. Thank you. Good points. There is another question from the chat box. Are there any practice tips or valuable tools to evaluate and manage these subjects, especially in the pediatric population with chronic urticaria, given that many PROMs are directed to adults? Monica Sandoval is asking this question.
Definitely, there is quality of life for children. As regards Professor Finlay on a Cardiff University website, there you've got cartoons. So there is something to start. But, you know, even my psychiatrist friends who take adults patients, they are very careful as regards touching to children because shall I say, of great patients. So it means parents. You know, you want to help, but then you have to have really specialists because it's very difficult actual situation. But anyway, for starting urticaria, no quality of life, this Finlay and co-workers questionnaire for children, it's available free of charge on the web.
Yes, there is a DLQE, children DLQE, because this is best to use this.
Okay, thank you. I think I have to close the session. I think we answered all the questions. So it was a great webinar. I learned a lot, and I hope our colleagues also enjoyed it. So please give feedback in order to get CME points. Here you can find the survey that you have to fill out. And also, I'd like to announce our next webinar, which is about recalcitrant urticaria, what to do when guidelines fail. So it's a very important topic. I invite all of our colleagues to this webinar. And also, please follow us on social media. By clicking this QR code, you will find links to the social media of UCARE. So thank you all, our faculty. Thanks to our participants. See you again soon in the next webinars.
See you in Brazil.
Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.
Lovely.
Thank you.
Thank you.
Bye-bye.
Bye-bye.